Bismillah ar-Rahman ar-Rahim. We'll talk about multimodality evaluation of patients with suspected cardiac amyloidosis. Our topic today will include the definition and classification of cardiac amyloidosis, red flag in clinical presentation, workup, echocardiography, CMR, bone scintigraphy, tissue biopsy, including endomyocardial biopsy, diagnostic workup, and diagnostic approach, and lastly, treatment. The definition of cardiac amyloidosis is an infiltrative disorder characterized by extracellular deposition of misfolded proteins in the heart that is caused by the deposition of the myeloid fibrils at the cardiac level. There are 42 amyloidogenic proteins have been identified to date. The two most common subtypes affecting the heart are and are accounting for more than 95% of the all cases are transthyretin and light chain amyloidosis. ATR is caused by age-related misfolding of normal transthyretin, which is called wild type, or immunogenic mutation in the TR gene, which is hereditary type. While misfolded immunoglobulin light chain can result in AL amyloidosis. So when to suspect cardiac amyloidosis in a patient who have unexplained left ventricular hypertrophy, in a patient who have heart failure and silent symptoms of amyloidosis, such as bilateral carpal tunnel syndrome, peripheral neuropathy, renal dysfunction, and other. Patient with aortic stenosis and echocardiographic picture associated with cardiac amyloidosis, including low flow, low gradient aortic stenosis, myocardial granular sparkling, abnormal left ventricular GLS, and others. So diagnostic workup start by the clinical suspicion. Clinical suspicion comes from the red flags. The clinical red flags include orthostatic hypertension, normalization of the previously hypertensive patients, peripheral congestion, heart failure with reserve ejection fraction, bilateral carpal tunnel syndrome, base extended rupture, lumbar spine stenosis, peripheral neuropathy, trigger finger, and proteinuria. The ECG may show low voltage pathological key waves on the two consecutive leads, conduction abnormalities, with pulse pattern, atrial arrhythmia, ST segment depression, and ventricular tachycardia. This patient will typically in advanced stage of the cardiac amyloidosis while showing a low voltage ECG, and there is also poor airway progression, so the impact pattern on the precordial lead or pathological key wave in the precordial lead. The echo will show reduced GLS with relative apical sparing, and typically we found due to apical sparing, apical GLS over the basal GLS more than 2.9. We may found in echo pericardial effusion, and immortality found reduced S, tab Z, and E prime and A prime. Also found a split dysfunction grade 2 or more, and low flow, low gradient aortic stenosis. Also, patient will have left ventricular hypertrophy, small AV chamber, and decreased extra volume. The decreased volume will be more apparent in the earlier stage of the cardiac amyloidosis before the reduction in ejection fraction. Also, we can see RP free wall hypertrophy, atrial dilation, thickened AV valve, and AV valve regurgitation, and granular sparkling in non-harmonic imaging or speckle appearance in harmonic images of the myocardium. The cardiac markers may show persistently elevated cardiac troponin, disproportionately elevated NT-proBNP compared to the clinical presentation. CMR may show diffuse endocardial or transmural enhancement, myocardial nulling before the blood fall, and extracellular volume more than 40% and decreased T1, T2 mapping. The workup of patient with amyloidosis is started by cardiac biomarkers. Cardiac marker has important role. The cardiac markers involving in the workup of cardiac amyloidosis are NT-proBNP and troponin. Persistently elevated cardiac troponin and unexplained and disproportionately elevated NT-proBNP compared to the HF clinical presentation should raise suspicion of cardiac amyloidosis. Cardiac markers are increased in the early stage of the cardiac amyloidosis even before symptom onset or echocardiographic evidence of cardiac development. Why? Because of the cytotoxic effect of the amyloid fibrils on the myocardial cell. The level of cardiac biomarkers can vary significantly based on the underlying mutation and degree of cardiac involvement. Their measurement is recommended as the first step in the diagnosis of cardiac amyloidosis. There is a study suggesting that NT-proBNP lesser than 180 and high troponin lesser than 14 nanogram per liter can reliably exclude diagnosis of cardiac amyloidosis before making patient to undergo bones angiography and monoclonal protein assessment. This study developed a study to test the diagnostic value of NT-proBNP and hydroxytroponin in patients with suspected cardiac amyloidosis. So they include 1,149 patients. Of them, there were armed with rule-out amyloidosis, which include NT-proBNP less than 180 and hydroxytroponin less than 14. This arm is reliably excluding the cardiac amyloidosis if the uh, result of the NT-proBNP less than 180 and hydroxytroponin less than 48. While patients who have high troponin and more than 86, including the rule-in or cardiac amyloidosis, is very light. So the conclusion this small study, cardiac biomarkers can define the diagnosis of the cardiac amyloidosis when NT-proBNP lesser than 180 and hydroxytroponin lesser than 14, cardiac amyloidosis can be excluded. Low level of circulating, so low level of circulating biomarkers can use safely to exclude uh, diagnosis of cardiac amyloidosis and avoid further investigation and non-invasive testing. Biomarker assessment should be combined with clinical and imaging parameter at the earliest phases of diagnostic algorithms systemic amyloidosis to support the further evaluation and decision making. Monoclonal protein assessment is very important in a patient with suspected cardiac amyloidosis. All patients with suspected cardiac amyloidosis should undergo assessment of, for the presence of monoclonal protein in serum and urine. Serum protein electrophoresis with immunofixation and urine protein electrophoresis with immunofixation and serum kappa to lambda and free light change ratio. The serum kappa lambda light change ratio is considered normal when it is between 0.36 more to 1.65. If the monoclonal lambda gamma is present, which will be indicated by the kappa to lambda ratio lesser than 0.26. While if the kappa to lambda ratio more than 1.65, which will indicate monoclonal kappa gamma. So the normal is between 0.26 to 1.65. The chronic kidney disease can elevate the kappa to lambda ratio in patients with moderate or severe chronic kidney disease in either stage 3 or stage 4 or 5. If monoclonal protein is detected, hematological consultation should be done and for evaluations with this patient, while negative serum protein electrophoresis and urine protein electrophoresis and normal kappa lambda ratio have negative predictive value of 99% for AL amyloidosis. The echocardiogram plays an important role, and it is easily taught to assess the patient with suspected cardiac amyloidosis. The left ventricular hypertrophy is more apparent in the transthyretin amyloidosis than AL amyloidosis, and is more pronounced compared to the hypertensive patient or the patient who have LVH due to valvular heart disease. The ejection fraction is still normal, even in the late stage of cardiomyopathy, but indexed stroke volume is typically significantly reduced. Impaired global strain, which is strain lesser than minus 13, with apical sparing sharing on top of pattern, and apical GLS2. Basal GLS more than 2 would suggestive cardiac amyloidosis. Average basal to mid GLS to 1, again, average apical over basal plus mid GLS. If it is equal to 1, this is can suggest cardiac amyloidosis with very high sensitivity is around 93 and specificity is around 82%. So this is six patients with cardiac amyloidosis. The first one with Fabry disease, second one with hypertension, third one with hypertrophic cardiomyopathy, fourth one with chronic liver failure, and fifth one with is athlete, and the last one is amyloidosis. In the amyloidosis C, all of them they share the hypertrophy, but hypertrophy it can be different pathology and different mechanism. So in the amyloidosis, we'll see the typical appearance of the granular sparkling, and we'll have also the Doppler diastolic dysfunction and reduce EA and S prime. This echocardiography of typical patient with amyloidosis, while granular and sparkling pattern, and cherry on top is present with the relative apical sparing. What does mean by relative apical sparing? The values of the GLS is higher in the apex compared to the base and mid segment. This is important to know, not must be normal apical GLS value. And also echo may show reduced S and A prime. Also, you can show elevated filling pressure. Uh, uh, this echocardiogram score developed to help in either diagnosis of patients with suspected cardiac amyloidosis and in patients who have amyloidosis to refine patients who have ATTR cardiac amyloidosis. So the most important AL score in fuel score the L score composed of relative thickness E to E prime and GLS and TAPSI, while inferior score, inferior thickness score consists of same finding plus septal uh, apical to base uh, strain ratio. So painter are assigned variables that meet the ideal diagnostic threshold, resulting in a score range from 0 to 6 for AL score and 0 to 10 for inferior thickness score. A mass to strain ratio is good. A mass to strain ratio of 11.5 provides 8% specificity and 79% sensitivity for identifying STR cardiomyopathy. These two score, inferior score and the score, as you see, the items or the points or the parameters they are consisting of relative thickness E to A prime more than 10 and relative thickness more than 0.52, which is different from the inferior score and tabs lesser than 19 and less more than 14. So first two items taking 2 points and the last two items taking 1 point. So if lesser than 1 point, so the cardiac amyloidosis is unlikely. The point more than 5 points, the cardiac amyloidosis is very likely and with good specificity. Inferior score, as we said earlier, composed of 5 items, same items, but different cut value. So relative thickness more than 0.6, different more than 0.5, and which is take 3 points. And E to A prime more than 11, tabs lesser than 19, GLS more than minus 13, and SAP ratio more than 2.9. The ABIX to basal GLS more than 2.9, which take the score. It's so important in the real score. This is three tables give you an idea about how the specificity of this score in identifying patients with amyloidosis. First one, identifying patient with ATTR, TTR, cardiac myosin, patient with cardiac amyloidosis. So we have patient cardiac amyloidosis. We want to know if this patient really have ATTR cardiac amyloidosis, then we use this score. The mass to strain ratio give you a nice specificity to diagnose the ATTR cardiac amyloidosis in a patient with the cardiac amyloidosis. And if you will thickness score, also have same value almost, and lastly, or other scores are lesser specificity compared with the MSR and inferior thickness score. So, in patient with ATR, how to diagnose ATR patient with fluid suspected cardiomyopathy. So, you have patient with suspected cardiomyopathy. You want to know if this is ATR cardiomyopathy or not. The best score is MSR and inferior thickness score, and this score gives us a good sensitivity by 29, 20s, and modality specificity for diagnosis. The last one is how to diagnose ATR cardiomyopathy in patients with suspected cardiomyopathy with hypertrophy. So the mass to strain ratio and fluid thickness score are good in evaluating these patients with a good sensitivity and excellent or very good specificity. Then we go to the cardiac MRI. Cardiac MRI is very helpful in diagnosing cardiac amyloidosis. The findings in the cardiac amyloidosis include diffuse or transmural late gadolinium enhancement or abnormal gadolinium kinetics and high extracellular cellular volume. The late gadolinium enhancement pattern can progress from subnuclear in the cardiac meliosis to transmural during the course of the disease. The normal wall thickness doesn't preclude the presence of abnormal late gadolinium enhancement. Notably, cardiac MRI, the gadolinium enhancement is more sensitive than echo for detecting of cardiac amyloidosis and distinguishing it from other cardiomyopathy with good sensitivity 88 and excellent specificity 94%. A negative cardiac MRI can safely use to exclude the diagnosis of cardiac amyloidosis in certain clinical scenarios, while a positive cardiac MRI significantly relate the suspicion of the likelihood of cardiac amyloidosis. Echo and MRI doesn't differentiate between the subtype of cardiac amyloidosis and extracellular volume more than 0.40% have been shown to be valuable in early diagnosis of the cardiac amyloidosis. So this is about the cardiac MRI. The cardiac MRI shows expansion of the extracellular volume, and also we have subendocardial enhancement, which is by time with progress to transmural enhancement. Next is bone scintigraphy. Bone scintigraphy is a key and important tool in the assessment and diagnosis of cardiac amyloidosis. The bone scintigraphy should be combined with SPECT to avoid false positive result due to blood pooling in the heart. Myocardial scarring can result in decreased cardiac uptake, while mitral annulus and aortic calcification can result in higher uptake, uh, making a difficulty in the diagnosis of this disease. Significant number of patients with AL ranging from 0 10 to 1 to 40 stage present some degree of cardiac uptake. So this is an example of scintigraphy where this is stage 0 and this is stage 1, stage 2, and stage 3 cardiomyopathy. And this again with respect to show the difference between this and SPECT, and also there is a comparison by the contralateral lung tissue, R2 to contralateral lung tissue as indicated by HACL. So, for bone scintigraphy, any scenario other than monoclonal morphine assessment and grade 2 to 3 myocardial uptake, if found such patient have grade 2 to 3 myocardial uptake and negative monoclonal protein assessment, this patient is diagnosis of cardiomyopathy ATR. But if found any other scenario, then biopsy is indicated in such patient. The biopsy is performed first, either from fat biopsy or salivary gland or bone marrow. But some sensitive biopsy site is that of the affected organ. So the best sensitive biopsy site is the affected organ, whatever is heart, kidney, or others. Identification of the amyloid subtypes is accomplished by mass spectrophotomy based analysis of the tissue, which is the gold standard, with sensitivity of 88% and specificity of 96%. So the role of endomyocardial biopsy, the endomyocardial biopsy should be performed if other tissue biopsy doesn't confirm the amyloid, and there is high clinical suspicion of the cardiac amyloidosis in a patient with amyloid with monoclonal protein and immune fixation and decreases and abnormal serum free of the capital and the ratio. So patient have high clinical suspicion despite he has positive monoclonal protein, then this patient have to go for biopsy and possibly endomyocardial biopsy. Second scenario, if there is high clinical suspicion of cardiac amyloidosis despite negative for because velvet scan. Third one is lateral cardiac scintigraphy. Fourth one, in rare cases where concomitant ATR and AL cardiac amyloidosis are suspected, at least 4 biopsy should be taken in endomyocardial biopsy. So, diagnostic algorithms of cardiac amyloidosis, there is many cardiac algorithm, either to start by the clinical scenario, as the red flag, MEDO, ECHO, or CMR to suspect the patient, then go to assessment of serum tablet free light change and serum and urine protein electrophoresis, then if negative, then bone scintigraphy, and if positive, light chain assessment. then do hematological workup, do tissue biopsy, whether in the fat or affected organ with concordant staining, and mass spectrometry. And lastly, TTR gene sequencing if you diagnose TTR cardiomyopathy. So this is a summary of what we talked. I start by the clinical symptoms, then um, blood test assessment, then refer if one or more value of this is abnormal, then refer to hematology. But if all are normal, then here you can go to scintigraphy, which is a non-invasive one. If it's positive, then TR amyloidosis can be diagnosed. If negative or indeterminate, then cardiac amyloidosis unlikely. But if the bone scintigraphy is not available, then we have a difficult um, scenario. Then we refer to for bone scintigraphy or invasive evaluation with heart biopsy. It is the positive one show positive concordant staining and show, typing by the mass spectrometry or the amino staining. So based the diagnostic algorithm based on the 99 barefoot scan or 99 barefoot scientifically can be divided after assessment of monoclonal protein into four scenario. First scenario of the scintigraphy doesn't show cardiac uptake, so scintigraphy have no cardiac uptake and the symptom of monoclonal protein are negative, then the cardiac amyloidosis is unlikely and that the diagnosis should be seeked. If this patient persists, then consider CMR followed by cardiac or extracardiac wave bone scintigraphy could be negative in some ATR amyloidosis. This is an example of the bone scintigraphy. The second scenario, scintigraphy shows some cardiac uptake and assessment of monoclonal proteins are negative. So in this scenario, cardiac uptake grade 2 or 3, um, and diagnosis of the cardiac disease should kind of be done safe. So if scintigraphy is positive with 2 to 3 cardiac uptake and monoclonal protein is negative, then we can diagnose cardiac amyloidosis, and this is the only scenario that we can diagnose cardiac amyloidosis in this patient. Third one is scintigraphy doesn't show cardiac uptake, and at least one of the monoclonal protein this is abnormal. Light change amyloidosis has to be ruled out promptly, and CMR can be used to confirm the diagnosis of the cardiac improvement. The last scenario is the scintigraphy was show some cardiac uptake, and at least one of the monoclonal protein is abnormal. So this is against the second scenario. There is specific immunoclonal protein. So transthyretin amyloidosis with concomitant FGOS, monoclonal gammopathy, undetermined intent, or any other hematological disorder that produce free radical. AL amyloidosis or coexisting both AL and ATTR amyloidosis are visible in this scenario. Diagnosis of cardiac amyloidosis in this case requires histology with amyloid typing via myocardial waves. So this figure summarize approach to assessment of to diagnose to suspect cardiac amyloidosis. Start with symptom signs, ECG equals MRI in serious patients. Then do hematological test and 99 technetium pair of spit scan. If the scintigraphy is negative and medical test is negative, then cardiac amyloidosis is unlikely. If scintigraphy is 1 to 3 with negative hematological test, then grade 2 or 3 cardiac amyloidosis, and for grade 1, then hematological confirmation needed. But if scintigraphy is 0, with the monoclonal gammopathy is present, then LDMS amyloidosis is the likely CMRI, proceed with CMRI or CMRI or CMRI with other modality if CMRI is inconclusive. If CMRI is negative, then amyloid likely. If CMRI is conclusive, then histological confirmation for cardiac or extracardiac diagnosis. Last scintigraphy show grade 1 to 3 and positive hematological test. This is other than the typical pattern for the positive amyloidosis, where here we can find histological confirmation, usually current to be done to subtype deviations in this case. The most important contribution of the bone scintigraphy in the diagnosis of subtype cardiac amyloidosis is that In case of positive myocardial taking grade 2 or 3 and negative monoclonal protein assessment. In this scenario, we can diagnose safely the cardiac myocarditis. The treatment of cardiac amyloidosis involves two treatments, either treatment and prevention of complication or stopping the or delaying the deposition of the amyloid by specific treatment. So specific pharmacological treatment available for the amyloidosis include stabilizing molecules is this and genetic silencer like Patisiran. These two medications are used in the treatment of the cardiac amyloidosis. So the tafamidis is the only drug of choice that has been effective in the randomized trial, patient with ATR wild type and variant doses with cardiomyopathy and should be considered in patients with reasonable expected survival. So this table summarizes the mechanism and the drug's name that's used to treatment of cardiomyopathy, like TTR protein stabilizer, clotrimidis, and used orally. TTR protein silencer, like Tiran, which is used for the patient with either cardiomyopathy and neuropathy or neuropathy around secondary to the amyloidosis. The TTR fibrinogen include the antibiotic, which is off-label use. This the figure shows you the mechanism how these medications work in the reduction of the TTR production. So the liver have is suppressing the TTR productions, while if the patient's the fibrils goes from the liver, then we have medication that do dissociation and the TTR stabilization in suspected patients, which is called tafamidis, the mortadella. Then, lastly, uh, if it is not available or not effective, then we go to the elimination of the deposition by doxycycline or doxycycline and DCA, and we use antibiotic for assessments. The TTR type amyloidosis, he had a summary of the amyloidosis. If the amyloidosis is TTR type with cardiomyopathy, then the treatment choice is tafamidis. But if the variant TTR amyloidosis, then if it is only leading to cardiomyopathy, then that tafamidis is the drug choice. But if it's leading to cardiomyopathy and neuropathy, then tafamidis is stage 1 neuropathy or tafamidis patisiran if it is going to stage 1 or 2. Multimodality alone, only we use tafamidis, the stage 1, patisiran if it's stage 2. So summary, so the stop, when patient with cardiac amyloidosis, when there is high clinical suspicion, do echocardiogram. If the echocardiogram showing healthy wall thickness more than 12 millimeter and any so of the lytic flag sign, then you should ask patient uh, for workup for cardiac amyloidosis. So, suspect, then those diagnostic criteria either invasive by cardiac waves or invasive by breath integrity and by the assessment of serum free light exchange and negative serum and urine immunofixation. The treatment of the cardiac amyloidosis, either treatment or by the disease modifying agent like tafamidis or the treatment of communication like failure, thromboembolism, and fibrillation, conduction of rheumatism, ventricular arrhythmia, venous stenosis. So conclusion, the appropriate diagnosis and subtyping of cardiomyopathy frequently missed or delayed due to its vague presentation, clinical correlated diagnostic pitfalls. The most important factor of timely diagnosis is increased clinical suspicion, especially in certain clinical scenarios. If the cardiac amyloidosis is the working diagnosis, certain step has to be taken for further assessment and for confirmation of the diagnosis. Appropriate imaging with echo or CMR can provide significant evidence for the diagnosis of cardiac amyloidosis. All patients should undergo monoclonal protein assessment with the results significant determine step to follow. A negative monoclonal protein assessment will lead to an invasive algorithm, which is in combination with cardiac scintigraphy can disability progressive ATTR cardiomyopathy. Tafamidis is the only drug of choice in the treatment of patients with wild type ATTR and free type ATTR with cardiac myopathy.